I really felt very good about my clinical skills. I had sort of achieved a level where I felt good about myself. And I remember taking care of this critically ill child for probably a month in the hospital. And then one night he was essentially dying. I had nothing else to offer him. And I didn't know what to do about that. I didn't know what I was saying. I tripped over myself in language. I made things worse.
If you're giving me this bad news, I want to know that you tried everything you could, okay? And then let me know that you cared for them in a way that I'm going to feel that they were taken care of.
You practice how to intubate, you practice how to operate, you practice. Do you ever practice how to give a parent bad news? And I can guarantee you, no matter what the bad news is, what the scenario is, if it's bad news, it's life-altering.
As I began to go into neonatology, I knew that I was going to frequently have to break bad news to families, and that was a source of a lot of anxiety for me. I worried that I wouldn't know what to do. I worried that I might stumble over my words or not be able to help the patients in their critical time. And so I took the opportunity as much as possible to ask senior physicians if I could watch them give bad news. There were certain patterns between the physicians who did it well and the physicians who didn't do it well. And I started to realize that this is a skill that could actually be taught. The Breaking Bad News model consists of 3 components. The first component involves the physician participating in improvisational role-playing using professional actors to teach young physicians how to communicate compassionately bad or tragic news to their patients.
She's 14.
But what's different about what we do is that we don't have a script. We don't have a script that you have to stay with. This is improvisation. And the residents are walking into a situation where they have to deliver very disturbing, traumatic, or distressing news to parents, sometimes who they've just met.
Well, what kind of parents do you think we are?
I'm sure everyone's cried when they come out of these. These are so real.
The second component consists of videotaping scenes with an expert panel of physicians reviewing those scenes live. And the final component, which I believe is the most important component of the Breaking Bad News, is the review of that particular scene immediately following the role-playing session. The participant or the physician reviews that scene with the expert panel.
And here are the things that need to happen.
Need to be done.
Okay.
Yeah. And this gives them an opportunity for self-reflection and self-review.
And I also feel like that heightened emotionality of the situation also reinforced the lessons that we were trying to teach.
Right, I mean, we've had hundreds of these conversations, and they're not easy. Even when you've been doing it for years, it's very emotional and difficult and draining. And
But you know what you just did there, for even though it wasn't real, to me that's more important than anything you do in the ER.
When I come to work, this is like every dad's nightmare, you know. So.
Oh my God, bless your heart.
In most cases, the person breaking the bad or tragic news to the patient is the physician, but also nurses, healthcare workers, social workers can also go through this program.
If there's one thing I've heard people in the community, patients, other family members complain about, is how doctors don't communicate well.
What we found after the success of the Breaking Bad News program is that many institutions came to me and asked if we could bring the program to them. But the reality of medical economics right now is that there's a limited amount of money to pay for the program. And so we started the BBN Foundation to allow people to donate money and support this program.
It will take commitment to the education of medical students, residents, and physicians and other healthcare workers so that whatever the news is delivered in a compassionate, empathetic, and effective way. I think it goes way beyond even what we started out to do, and I'm very excited about what we can do with this program in the future.
And if I don't have the answer to them, I will get them.
Oh, that's great.
Perfect.
That's fantastic.
Okay to say
I love that. If we can start training physicians from early on, then maybe 20, 25 years from now, they'll all be trained or be BBN certified.
The truth is that I really did come to medicine to be in a specialty and be in a part of people's lives, to really be able to talk to them.
When you're in the hospital or you're dealing with a medical concern, you just remember a lot of highs and a lot of lows. And how information is conveyed to you about your child can really make the difference.
If the family can go away with that, from feeling that you did everything you could possibly do, you reached out to them in a way that they could understand it, that you don't increase their pain. They'll always have the sadness over the loss or over the diagnosis, but they feel it was a shared experience and that you connected with them at some level, and that will become a very positive experience. But it's a long process to learn it. It's not an easy process.